My name is Neil Asaf, and I'll be presenting our work studying the efficacy of intratympanic steroids for idiopathic sudden sensorineural hearing loss. Idiopathic sudden sensorineural hearing loss, or ISS-NHL, is defined by acute hearing loss that develops within 72 hours with decreases in hearing greater than or equal to 30 decibels at 3 consecutive frequencies on pure tone audiometry, with pure tone audiometry being the main hearing test used to identify hearing threshold. Generally, when treating ISS-NHL, oral corticosteroids are used. However, an alternative option for treatment includes intratympanic injections, which may be more beneficial due to increased steroid concentration at the target site and decreased systemic corticosteroid exposure. A multitude of studies have been conducted trying to determine treatment outcomes for patients with ISS-NHL after IT injections. However, these outcomes vary significantly due to the different criteria used for defining the response to treatment. Our study specifically addresses the issue of variable response criteria by utilizing the recent American Academy of Otolaryngology Head and Neck Surgery, or AAO HNSF guideline for hearing recovery as the standard by which to assess the efficacy of IT steroid for ISS-NHL. Thus, we hypothesized that the efficacy of IT steroid treatment for ISS-NHL will differ based upon the outcome measures used. To test this hypothesis, we first started by conducting a retrospective chart review of the MCW/Rader system, which identified 74 patients diagnosed with the ISS-NHL between April 2003 and December 2020. Inclusion criteria was specific for patients with a prior diagnosis of ISS-NHL, at least one treatment with intratympanic steroids, either dexamethasone or methylprednisolone, and who had undergone pre-treatment and follow-up audiograms. Patients presenting with ISS-NHL with known causes of ISS-NHL, such as Meniere's disease or acoustic neuroma, were excluded. Further exclusion criteria include patients with contraindications to steroid treatment, such as diabetes and hypertension, and a lack of initial and follow-up audiogram. Transitioning to the results, in Figure 1, we can see a graph that shows the breakdown of recovery per recovery condition, which include full, partial, or no recovery, specifically for pure tone average 4. PTA4 was specifically chosen due to its universal clinical use. When taking a look at number 1, the AAO HNSF, we can see that the proportion of patients that fully recovered was about 25%. When comparing full recovery per the AAO HNSF guideline to the other papers, we see a variability in recovery rates of about 26%, with both the Kwok and Koltsidopoulos papers showing full recovery of about 41%, while Siegel and Furhosh papers showed full recovery rates of about 15%. Looking at the partial recovery condition, we see that AAO HNSF guidelines showed recovery rates of about 22%. When comparing the AAO HNSF guideline to the other papers in the partial recovery condition, we see a variability in recovery rates of about 10%. The proportion of patients that showed no recovery using the AAO HNSF guideline was about 50%. Variability in the recovery rates for this condition was about 30%. In Figure 2, we can see two graphs that show the differences in response to treatment with IT injections between the high and low frequencies. When comparing the graphs, we can see that the treatment response in the lower frequencies was significantly higher than those for the high frequencies. Partial recovery was also higher in the low frequencies compared to the high frequencies. In Figure 3, a graph is shown depicting the differences in hearing recovery between the low, mid, and high frequencies prior to and after IT steroid injection. In the graph, we can see that the low and mid frequencies seem to improve more than the high frequencies. Finally, in Figure 4, we can see a graph that shows the recovery rates for patients with varying levels of hearing loss. As we can see, patients in the bottom 25% of hearing loss had significantly more patients fully recover compared to patients in the middle 50% and upper 25%. Those in the bottom 25% showed full recovery rates of about 52%, while patients in the middle 50% and upper 25% showed full recovery rates of about 18% and 14% respectively. There were no patients that partially recovered at the bottom 25%, and patients in the upper 25% showed a higher proportion of partial recovery compared to the middle 50%, with approximately 48% of patients reaching partial recovery compared to about 21% for the middle 50% of patients. When determining the efficacy of IT injections for ISS-NHL, we can see that the recovery outcomes varied greatly depending on the criteria used. With variabilities in recovery rates reaching up to 35% in some cases, it makes it difficult to develop an evidence-based approach for the use of IT steroids. Additionally, without a standardized guideline for use in the assessment of hearing improvement after IT steroid treatment, it is challenging to justify the cost-effectiveness of IT steroids as compared to oral steroids, as the latter is a much cheaper option. Thus, the use of the AAO HNSF guideline to standardize outcome reporting in future studies is essential to determine the efficacy of IT steroid for ISS-NHL. In conclusion, future studies should use the AAO HNSF guideline for consistency in data reporting and in order to be able to compare outcomes of IT steroid injection for ISS-NHL. A limitation to this study is that we were unable to evaluate outcomes in the other studies using the AAO HNSF criteria because those studies did not list individual patients to allow such an analysis. However, a major strength of the study was the use of the alternative ear as a reference for hearing improvement, as opposed to other studies that used hearing improvement as just a change from the level of hearing loss in the affected ear. For future work, the AAO HNSF guidelines should be used during clinical trials regarding ISS NHL. I would like to thank the Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin and the NIH for funding this work. Thank you for your time.